Well, and Dr. Duchesne is our speaker today, and I'm going to introduce him. He's a good friend from many years ago, and it's one of the most important people that publicate and make some research about uh, shock and all the stuff with that this represents. So thank you, Juan, to be here with us, and it's a pleasure to have Dr. Rodriguez also with us too. Thank you.
All right, thank you, everybody. I'm going to start doing share screen. And let me know if you can see my screen.
Yes, it's perfect now.
Perfect.
That looks good.
Okay, perfect. Well, thank you, everybody, for joining. I think that this is a topic that everybody is kind of like jumping in and trying to figure out if it's, first of all, feasible. And if it's feasible, what are the outcomes that we're getting here in our trauma center? So I decided to talk about a little bit of the history of through the years that I've been through doing this resuscitation in trauma. And all this started back in 2006. So as this to me is like almost like a reflection of like a time to pause to see if actually we are really doing that good. So that's why my topic is called Moving the Pendulum of Resuscitation. And one thing that I like to talk about a lot is that every time or any time that you hear somebody coming up with a new idea that is different from the status quo, there's always a lot of resistance. And I want to say that to all the new residents and anyone that is in the education part, because that's the nature of the beast. In order for us to do better, we need to get away from that box, and we need to think out of the box in order for us to make changes, especially in resuscitation and outcomes. So this is pretty much a history lesson on my side of what I learned. So as we know, bleeding patient life is on the clock, time is life. And through the years, some of the things that we've seen that have helped in the trauma center, from the utilization of tourniquets, the utilization of a blood safe in the emergency department, rapid infusers in the emergency department, and anywhere in the hospital. And then damage control resuscitation, which basically have prolonged that window of resuscitation in these kind of patients that come in extremes. So damage control plus damage control resuscitation definitely have make a big impact in the way we resuscitate and take care of our trauma patients. So like I said, all this started back in 2006 for me. And our first paper actually came out regarding one-to-one resuscitation, came out in 2008. And since then, I've been trying to look at what have we done? What is the difference in outcomes, if any? So because of that, I decided to take a look at this analysis of 800 MTPs that our system has been exposed to. And we decided to, as like everybody knows, there's been a plethora of papers out there that basically said that these patients are doing great. 1-to-1 is better than 1-to-4, 1-to-2, whatnot. So there's a lot of information out there saying the benefit of this resuscitation modality. So what we decided to do is to have, basically, we decided to look at our trauma center, and we hypothesized that actually the mortality over time will be decreased in later years, which will have utilized many of these advances of damage control resuscitation. So we did a 12-year analysis at our trauma center of all MTPs. The interventions by year of implementations were 2009, we finalized the MTP in a 1-to-1 ratio for all patients coming in. Liquid plasma was introduced in 2010, ready available in the emergency department without being defrosted. tranexamic acid, 2012. Tourniquet utilization, 2013. Also, it was used way before that, but it was finalized and it was a guideline in the pre-hospital in 2013. Reboa and TEG utilization, 2017. ED satellite blood stations or satellite blood refrigerators in 2018. And whole blood transfusion in 2019. So we look at all the NTPs, and these are basically the 12 years. And out of that, we, from basically 30,000 cases of patients that came through the system, we identified in those 12 years, 800 patients that actually used NTP. And this is what we found. We found that during that 12-year period, our average mortality rate, believe it or not, was still in the 40%. And this was no different from many other institutions that have looked at this, where basically the mortality haven't changed in that 40% range. What we identified is that the utilization of tourniquet and the utilization of whole blood have been, were basically like markers that actually there's a survival benefit. So if you think about this, we're talking about one modality that is about volume retention and the other modality, which is effective resuscitation. So these two things look like they were sending a signal, but remember, this is all inside the hospital. So still mortality in the 40% range, right? When we look more into the details of where these patients were dying, in red is basically the mortality of the patients that died in the ER. These are patients with severe hemorrhage, en route hypotensive. And as you can see, for extremity, less than 50%, barely at the 50%, they died upon arrival to the ER. Junctional, torso, you can see that the mortality in the ER arrival is actually very high for those that were in extremes. So this is sending a signal to me that maybe we are not really effectively doing that much once they arrive to the hospital. Maybe the horse, what they say in the United States, is out of the barn, meaning these patients are going to die no matter what, because we're not doing anything in that time where they got the injury when when they arrived to us. Maybe we're too late. So I did more readings, and I started looking at all the papers, and actually identified this great paper from my friend Brian, where basically he started identifying that this golden hour myth is a myth. Patients with severe hemorrhage, and I want everybody to pay attention to this, patients with severe hemorrhage, they die within the first 30 minutes. Keep that in mind, within the first 30 minutes. Very nicely described in this paper. So we decided to look at then, if we know that it's 30 minutes, what is the time that it takes in the United States to stop the bleeding in these patients in the OR, right, surgically? So we look at a bunch of trauma institutions and a bunch of patients, and what is really intriguing to me is that most of the patients, if you look at right here in this area here, the pre-hospital, you can see that the pre-hospital time is within that 30 minutes. Now, go back to that graph I presented, saying that these patients are dying on arrival. Well, that goes along the lines of what Dr. Brian Eastrich is saying. These patients' mortality is within the first 30 minutes, but we're not getting to them within 30 minutes to the hospital. That's why they're dying in our door. And when we look at the time that it took from initial injury to the time to go to the OR in the United States, it took 74 to 88 minutes. Remember that, 74 to 88 minutes to get a non-compressible torsal hemorrhage hypotensive patient from the scene to the OR. So now I hope that this is like putting something in your brains telling you, wait, so whatever we do in the hospital is not going to fix this patient. So is it time to move the pendulum of resuscitation? And this is where we are right now. And after working a lot with the military here in the United States, we've been trying to create an adaptation in the civilian world from what the military have done. And that's why I call this, is it time to adopt the advanced resuscitative care in the civilian setting? So what I'm going to present now is a real case scenario. This is not a mock case. This is a real patient that after a home invasion was shot through the left arm into the chest. And this patient presents to the emergency department. EMS presents to where the patient is at their house. So let's go ahead and see the video, and we're going to be asking questions after that. So this is a penetrating trauma case scenario.
Building's gonna be set up at the.
Hi, so we have an entrance through one going through. He has lung sounds. Looks like a 5 or 62.
Okay.
Can you see how what I'm thinking
I'm dying.
with the way that the gunshot wound is? Enter here.
So
He's got crepitus under his left axilla. Feel this crepitus here?
Yeah. Okay, well, we know that one's down. Yeah. All right, outside. We're losing it.
So as you can see, this patient has a penetrating injury to the left arm and looked like it went into the chest. EMS is telling everybody we're losing him, and the patient is telling everybody, I'm going to die, I'm dying. So for those of you that have been in that environment, and whenever a patient says that, you know that's actually very accurate when they say those words. So let's go to our first question. Based on the patient vitals, the best thing the emergency medical service can do, EMS, is press on the gas, scoop and run, stay and play with advanced resuscitative care, or scoop and control bleeding with advanced resuscitative care, and that's basically without delaying transfer of the patient. So in the past, we always keep saying, and still some places they keep saying, press on the gas. That's all you got to do. Get the patient to us. But I'm going to present some information and some data here that is dead wrong, especially in a rural and urban setting. So for this case scenario, this patient needs to have a scoop and control with resuscitation with advanced techniques.
Your lines, get your blood. I've been 16. Sounds good. Let's hook our blood in. You come over.
Blood's working.
Take our tag on, but that's fine.
Yep.
But his cardiac arrest will be from exsanguination.
Sure.
Get ready for
Pass me the IO.
and let's get, and then as soon as we get the IO in, let's get him ready for it. Or monitoring, make him naked.
The second poll question is, with impending cardiac arrest, the priority number one for this patient will be airway intubation, breathing with a chest tube, or nothing, need to rush this patient to the hospital. And through the years of my education, I was always told this patient needs to be intubated. And I'm here to say that that modality is changing. For this patient, the reason why his mentation is going down, the reason why he's doing poorly with blood pressure is not because of the airway, it's because they're bleeding out. So circulation is number one priority for this penetrating chest trauma. The third poll question, in the presence of tragic hypovolemic shock, the best fluid to give by EMS in this patient will be, and from all those, we have basically changed the modality to more and more packed red blood cells or whole blood. And that's where basically we're trying to move the pendulum of resuscitation in the pre-hospital in the setting.
You ready for blood? There you go. Holy crap. This bag turn itself inside out. It's going so fast.
When you start going to the LZ as well, you can start your driving.
Dr Duchesne, cooperation.
Let's drop our section. Be ready for that. We'll get him intubated after we open his chest wall. Ready to open your tongue? Is he done? Downward. There you go. Perfect. Good enough. All right.
In.
Feel hot?
Yep.
Pull apart. Hard. All right. significant hemothorax on the left. All right, put your finger in there and just get it as wide as we don't need it until we're ready. Let's put the cannula on to get him doubly oxygenated. Back up to 94 down here on ours. Okay, sounds good. Well, he's 96 on ours. I just want, I don't think he's got an oxygenation problem, but just know that when we intubate it, he'll rest.
99/60.
Perfect. So we got blood going into both.
That one going
Okay. Got another blood pressure going, 100/63. I'm convinced that with the continued infusion of blood products that he will hopefully, and as a result of suspension pneumo, he won't arrest. One more blood pressure.
All right. What you is there was basically the steps to avoid intubation. So this patient was heavily resuscitated with blood products, and you can see how that blood pressure went all the way up. So the last, or actually the second to last question, as part of the advanced EMS should be properly trained to perform which one of the followings? And it's pretty much all of the above, from cracks, finger thoracostomies, point of care ultrasound, and blood transfusion. So this is a modality that is emerging more and more in the United States. Is, believe it or not, also a lot of people will say, oh, we give blood in the hospital setting. The fact is that in the United States, only 3% of the EMS services are given hospital blood. So there's a lot more to do to get everybody involved. So I hope that based on these scenarios, you're thinking of airway, breathing circulation versus circulation first have changed. And I hope that everybody will say yes to that. So, so basically, after that kind of presentation, EMS and a lot of friends start talking to each other, and we decided to put this paper together called Selective Pre-Hospital Advanced Resuscitative Care, SPARC, Developing Strategies from Non-Compressible Torso Hemorrhage. So what you can see here is basically what we're basically described in those videos. We basically put it in a piece of paper that we need to develop a techniques for EMS to do scoop with control and resuscitation in order for this patient to be properly or arrive to our hospital with good signs of life. This paper has been heavily cited from the Shock Journal, and it's one of the most cited papers in the journal, and from the senior Dr. Remick telling us about the success of the paper. So in the EMS, there's a lot of things we can do. There's a lot of things we can provide there. But it's not just about bringing a doctor to the field. That's not going to fix the problem. But what it is about leveraging the system so it will work for the patient. So what can we give to the patient to make it more even for them to arrive to the hospital with signs of life? So which one out of all the best way to do this? We don't know. We don't have the right answer yet. But what we know is that control and resuscitation are definitely key components to get these patients to our system. So now I want to give you a little brief presentation of our in our urban setting in Yolney. And basically, this is the first paper that came out that got published at the Journal of Trauma in January 2024. And it's basically called Refill in an Urban Environment and actually save lives. So we decided to look at the patients that received that advanced resuscitator care bundle to the ones that were controlled that did not receive anything. No blood, no calcium, no TXA. And what you can see here is for the ones that were in the ARC bundle, the shock index was lower. The injury severity score were the same between the comparison groups. The mortality within 24 hours was actually significantly lower, and the in-hospital mortality was remained. So this bundle of resuscitation in the hospital setting definitely created a survival benefit. What is interesting is that the pre-hospital time, like many people say, just press on the gas, really didn't make a difference in patients' outcomes. So this is basically saying that it's not about how fast you get to the hospital, but rather how fast and what they need. So we compare our analysis to the refill paper that came from United Kingdom, that basically they demonstrated that crystalloids and blood did not improve outcomes in their study. Now, remember, in their study, the first unit of blood was given after 45 to 50 minutes of the patient injury, okay? In our study, we're giving blood to our patient within the first 8 to 15 minutes of patient contact. So that's why their mortality from 42% is so high compared to our mortality, which is 10%. So it doesn't matter if after more than 30 minutes, we already talked about this, the ones that are gonna die are gonna die. So can you affect that by giving blood way early? So the second thing that we decided to look from our experience is to look at if there's an impact in the ABCDEs by getting rid or actually modifying circulation first before airway. And this is actually from the chair committee from the ATLS last year, where basically he mentioned for the first time that exsanguination as an X stands before ABCDEF. And that underneath is the YouTube website that you can actually hear the recording of his presentation. So we were invited to this meeting, and we actually put our thoughts into this, and then we brought it back home and we analyzed it. So in basically our program of advanced resuscitative care in Neon started in 10/21, and with prioritization of circulation in patients with severe hemorrhage and penetrating injuries. This is our team giving blood in the pre-hospital setting.
TXA is in.
TXA, calcium, and blood.
Yes, and
So this is our protocol for pre-hospital patients that have a systolic less than 70 and or systolic less than 90 with a heart rate greater than 110. EMS will then have ready available in their pack 2 units of blood, 2 of calcium, and 2 of TXA. All this will be given to the patients prior to patient arrival to our trauma center. Remember, our transport time is 10 to 13 minutes. So even in a very fast-paced setting, our patients are getting these products way before arrival. So this is a geospatial heat map where basically all the patients are basically being picked up. And as you can see, as of 2 weeks ago, we were in 251 administrations of blood products. So you multiply that times 2, that's how much blood we've given in the last couple of years. And as you can see, where the X is our trauma center, and that's where most of our patients are located. So then we decided to look at this circulation first approach. Similar analysis, but what we decided to do is to look at the ones that receive circulation first in the ARC bundle versus the one that received airway first. And what we identified, and this is a paper, this got published in the Journal of the American College of Surgeons, the Blue Journal, in 2024, January. And this is breathtaking because what we identified is that those patients that had circulation first approach done first, the mortality was in the 13%. But for those that were intubated first and then resuscitated, the mortality went sky high to 47%. You heard that right, 47%. So this is something that needs to raise eyebrows everywhere that you go. And if you are connected to EMS, this needs to be brought to their attention. And even in any critical care environment, this needs to be discussed, right? Circulation volume tanking is of the essence, not intubation, because you're going to crash the patient's going to code, and you don't have anything to work with. So in our conclusion, pre-hospital hypotensive patient with penetrating injuries, ARC basically utilizing blood product first prior to intubation improve patients' mortality. Last but not least, I want to talk about the main difference, even in a fast-paced environment, of the benefit of getting blood in the pre-hospital setting, even if the transport time is 12 minutes, 8 minutes, 30 minutes. What we identified when we wanted to study is, and for those naysayers that, oh, we have a very fast pace, we don't need that here. Well, I have the data here to prove you that you're dead wrong. And what I'm trying to get to is that when you look at the mortality for this kind of patients, when blood was given in before the hospital, okay, there was a big survival advantage rather than waiting for the patient to arrive to the hospital when they get their first unit of blood. Furthermore, this is our statement. Compared to patients who first received blood after hospital arrival, resuscitation with blood products was started 19 minutes earlier. All right, 19 minutes earlier after initiation of a pre-hospital blood program, despite a 5-minute increase in pre-hospital time. A survival for early pre-hospital blood use was demonstrated with an 11% mortality increase for each minute delay to blood administration. So, my friends, I basically have to show you right now with good evidence why these patients are arriving dead to your centers. We need to give them the blood products as soon as that EMS contact occurred, not when the patient arrived to the trauma center. We basically did our first Spark Academy in March in 2024 in Florida. We're doing our second Academy in June, and hopefully one more in the fall. And I'm going to show you now a quick video clip of all the things that actually we do through the Academy. In our first Academy, we have a lot of first responders from EMS, tactical teams. We have the FBI was there, the SWAT team was there, and a couple of Navy SEAL special training team showed up. So it was amazing to see more than 250 people in one room listening to just means and ways that we can affect outcomes in this group of patients.
We're already like, hey, start blood. I'm going to keep working this massive hemorrhage.
So that little girl that you guys saw in that video, she's 6 years old. She had a tonsillectomy, and that night, one of the stitches blew out, and she basically was exsanguinated in her house. Her dad was the captain of the fire department in that region. So he calls the dispatch center, and one of the things that he mentioned was, we need blood. So they came in with units, whole blood. This little kid, Sissy, she received those 2 units of blood en route per kilogram. And basically, she was awake, alert, and she was able to join us. And she was our first survivor award recipient. So with that, I'm going to pause at this point, and I will be basically stopping my presentation, and I'll be more happy to answer any questions.
Juan, it was a great presentation. Good afternoon. I'm Albert Veron from Ryder Trauma Center, and I have 2 questions.
Yes.
The first one is, do you have a way to warm up that blood that you're giving per hospital? The reason I say that is giving frozen blood to a patient, it doesn't do them a lot of favors. That's the first question. And the second, if you assess the effectiveness of Spark comparing penetrating versus blunt trauma.
Yeah, so the first question regarding cold versus warm, right? So I think that one of the things that we're looking at is specifically at the outcomes. Right now, we have a lot of basic science behind the doors working specifically on this, because we're trying to figure out what is more effective to reestablish that circulation for ATP production and thermal protection, rather than just heating up blood and just heating it up. And we don't know yet what is better, but what we know is that in our group of patients, when we look ad hoc, our temperature difference, even with cold blood given in all of them, our temperature basically never dropped from 36.7 to 36.5.
But
So-
what I meant is there any way that you can have a warmer? Now, I'm not saying not to give it, is that you can warm the blood in the ambulance, you know, have a ranger, have a device that you can give, instead of giving frozen blood, you can give it fast, but run it through a warmer.
Yeah, we did that in our team. Basically, after 15 trials, they did not see a difference in the blood temperature when we're just
you touch that back. That's frozen blood that you're putting into the patient. It just doesn't, you know, it may not be as effective as warm blood, you know, from all characteristics. So
yeah,
I would be concerned about that.
Definitely a good theory. But you know, we're looking right now to make sure that we have the evidence to back it up. So
what about penetrating versus blunt? Obviously, in penetrating trauma, I'm an anesthesiologist. Intubating somebody penetrating trauma is just going to decrease the venous return. They're going to do worse. I have no problem with that. But in blunt trauma, specifically traumatic brain injury, airway may not necessarily be the third one, may still be the first one on the list. Again, blunt trauma with TBI, airway may be more, and penetrating seems like, you know, circulation goes first. What do you think?
Yeah, no, you know, most of our patients, 95% unfortunately are just penetrating. So that blunt trauma cofactor is going to play a role in the multi-institutional analysis. We have right now 400 patients, 8 trauma centers, and we're going to start looking at that because they're heavy blunt. They're not like ours. So we'll see.
Yeah, because think about it. In most institutions, including ours, even though we have 5,000 trauma admissions, most of the trauma that we see is blunt, correct? You're talking 75%. Places like you, if you just see penetrating, it's a little different animal from that standpoint. Thank you.
But we'll see, my friend. We'll see how that checks up. Hopefully by next AAC meeting, we will have our 500 cutoff patient list, and we'll start putting some outcomes out there.
There's another doctor there.
Dr. Rodriguez?
Yeah, congratulations, Dr. Duchesne. That's what I am very proud of you, seeing so how high you have arrived. That's what you deserve to be, maybe president of the Pan American Trauma Society, political advertisement. But I congratulate you for this paper, but this is a presentation. I have a question. By the way, do you notice, everybody, because I'm foreign, maybe I notice in all the papers, the word, they don't say decrease, they say mitigation. Everything is the word, they're 10 times or 15 times in the paper, the word mitigation. This mitigate means, translation, decrease the complication. Now, how about, I have this feeling, you know, I know it's a little papers about coagulation first, circulation first, breathing seconds, etc., etc. People is going to make a song with this. You prove that this is true. However, in my experience in the hospital, which I agree with you is better than the pre-hospital, the things are done at the same time. At the same time, somebody is doing the circulation, is doing, I never seen in trauma, shock trauma, for example, that first they do everything else at the same time. They intubate the patient at the same time they put in the circulation. So maybe I suggested you, unless I'm going to write a paper, now I'm going to change this. Maybe you got to make a paper in which they do at the same time, both things, you know, and see the difference, you know. I don't know. It could be an advantage. Maybe it'd be better that way, you know, because what is the point, you know? You give a blood because you want transportation of blood, of oxygen, correct? You know, but if you don't have the oxygen to get, then it doesn't make a difference. So I suggested you, the next paper you're going to write, because I'm going to death by that time, I'm 81 now, you know, you should write a paper using both at the same time. And I was going to say the same question about the penetrating and blunt. The time when I was in shock trauma, you know, 80% of the patients were blunt. And then they came with the politics, and we start seeing penetrate. I can see that Miami is still more blunt than penetrate. All right.
That's a very
my suggestion. What do you think?
No, I appreciate your suggestion. Unfortunately, I'm a physics nerd, and everything in life has a time. So even if we say that it happens at the same time, there's always a logistical fashion that you will say this happened first, right? So, but I agree with you. I think that the essence here is assessment. Wow, we need to intubate. Let's get this rolling. Let's get the circulation running. And that's what we're doing right now in our trauma center. We're doing a quick timeout where we assess and we said, do not intubate. Let's get this first, oxygenate, pre-oxygenate, get it to 100%. And then we go ahead, once the circulation is running, boop, intubate. So yeah, it's a team effort. It needs to be coordination.
Dr. Duchesne, you have two more questions, one for Dr. Pilazzi and another from Dr. Ontrack. Dr. Pilazzi, please, your question.
Thanks so much. Thanks, Juan. Very nice presentation. I wanted to ask, what's your goal for systolic blood pressure on patients without a TBI or spine trauma? I'm just asking because, like, normally for damage control resuscitation, initially we were told that we should aim for a systolic of 80 or 90 in order not to pop the blood and to reduce the amount of cooling that we can do with it by giving products, and of course by diluting bleed clotting factors. So I thought in that case that you presented the patient wasn't around 80 to 90. So is there a plan in order to change that goal? That should we aim then for normal systolic blood pressure, or should we still have a different target in order to reduce, like having an hypotensive resuscitation as part of the damage control resuscitation? Thank you.
Yeah, that's a very good question. And actually, I have a paper right now in Evolution called "The Death of Permissive Hypotension," because we're bypassing that, right? We're not. What we want is to establish that circulation again, knowing that these patients are going to go hopefully to the OR. So I think that there's more to come from our data. We're going to start looking specifically into that. In our first glance, when we look at that, with the patients that were basically hypotensive, meaning in the 90s to 100, actually had a worse outcome than the ones that were above, but that is multifactorial, right? That can mean a lot of different things. Was the patient still with severe injuries compared to the other ones? So it's going to be really hard to define this, but what we know is that the ones that arrive with a better shock index after blood resuscitation are having a better outcome right now.
So you would propose then target on shock index more than systolic level?
Yeah, any shock index that is definitely less than 1 in our group. The 0.7 is like the magical endpoint. Thank you.
I want to make another comment, if okay, regarding the question that was just asked. So if you look at the entire literature of permissive hypotension, there's a lot of animal studies showing that for blunt and penetrating, it's good, better outcome. Clinical studies, there's only one, and it's for penetrating trauma by the Bentop group. It's all penetrating, correct? One single study with a minor 0.05 that nobody has been able to repeat. And out of that came the entire hypotensive resuscitation thing. It was pre-hospital, not hospital. As you know, a very famous paper. The only random, all the other studies, Rex study, when they tried to repeat it at Bentop, have shown no difference at all. I think that the bottom line is for penetrating trauma, it makes sense to keep pressure around 80 to 90. For blunt trauma, that's a different animal. Especially you have TBI, because the studies have shown 150% mortality, the blood pressure goes below 90. So I would say that for penetrating trauma, keep the pressure low, 80 to 90. For blunt trauma, either normal, not hypertension, but do not let the patient get hypotensive. I think that's the bottom line. The other thing is, many of those studies show that we're not that good at targeting blood pressure. I'm an anesthesiologist. I think that you guys think that I can just say, I want 70, I want 80, I want 90. We can't do that. We just want to get some pulse and some back. We're not that good. But obviously hypertension is bad. But that's my 2 cents regarding permissive hypotension. And I know the people that wrote those 2 studies, okay? And they both show futility, but they still quote as those papers are the ones that show the hypotensive resuscitation is way to go. I look forward to your paper on the death of hypotensive resuscitation. I will be the first one to read it. Send it out.
Are you referring to the paper on Mattox, the classic?
Mattox, that's correct.
Of course, you know Mattox. You know,
Yeah,
they
and
were talking about patients who were 2 blocks away.
that's correct. 75%
Well,
was
you have 2 blocks
penetrating.
away, you
And
can keep the pressure at 90.
75% penetrating patients, most of them were thoracic. And it makes sense. If you penetrate the heart or you shot the heart, you don't want to get a blood pressure up. And so that's a small group of patients. And when the same group tried to repeat this study a few years ago by Carrico, they couldn't reproduce it. So
yeah, no, that's very good discussion. And I'm assuming that it's not just Maddox. I know Paul Pepe is another hard-headed on that.
You know, it's very interesting that Dr. Cowley will be very upset with this, you know. The golden hour, the golden 1 hour, a patient will be dead twice, right? Because it's 30 minutes. So all this,
30 minutes.
you know, shock trauma was created politically and based on the golden hour. It didn't exist. He created that name for the politician could understand, you know. But now, if you talk about the golden hour, you're talking about the 30 minutes, you know. So that's better. So everything is changing. When I came out this country in 1971, we resuscitated with crystalloids. Was Tom Shires. You know, Tom Shires said you had to give fluid to everybody with killing. Can you imagine so many people? Even the ATLS teach, you know, 2 liters of crystalloids before giving blood.
Now that's 1 liter on the latest guidelines until the new ones come. It's just 1 liter.
That's the old ones who don't want to leave the college, you know.
No, great discussion, definitely. Great discussion.
May I add something more, Juan? Another thing, I think it's just because we were told that one of the things that the popular clot, and that I totally agree with the penetrating trauma, but the second thing was dilution of clotting factors. And of course, we were told that we were using mainly packed red blood cells. Probably that might be different as well if your first blood is whole blood. You might dilute less these patients, unless you're pregnant, of course, but that would be different, would be a different later.
No, that's a very good point, Carlos. And you know, in our institution, we're only allowed, not allowed, but because of finances, component PRBC is easier and cheaper to give versus whole blood in the pre-hospital arena. So, but when we have data right now, like I mentioned, that is going to be close to 500 by this summer, and just a little lanyap looks like there's a way better survival benefit when whole blood is compared to PRBC. So, and I've been looking at this data, been tracing it, and look like the outcomes are very straightforward. I know that has been studied before by Lights, but this will be kind of a interesting another study to put it out there, because look like whole blood has definitely that healing and coagulation profile is making a big difference early in the game.
I had to ask you a question since it's hard to catch you sometimes. You never answer my call, so okay. It's about damage control. I know this is damage control resuscitation, but this is bothering me, you know. There's any paper written about what are the indications when you're in the belly to go into damage control? You know, they tell you, oh, hypothermia, coagulopathy, or coagulemic thing, but a triad, now calcium. But tell me, is any paper saying specifically why this guy get out? It's because he was scared, oh God, I had to call somebody else and go in damage control. So, or is because it was, what percentage was for coagulopathy, what percentage was hypovolemia? I don't think there's a paper written. It has been a generality. You say, oh, if the patient has this, you have to go into damage control. Do you know any? You wrote a book on damage control, so tell me.
Well, I'll be honest with you. Those papers were, and that all that movement by Michael Rotondo was based on damage control surgery, not with addition of damage control resuscitation.
I agree with it, yeah.
You know, so now that we are kind of masters of the resuscitation aspect, I think that it is time to start looking into this. And what are, let's say, we are in a state right now where hemorrhage has been controlled. Everything is being controlled. Let's look at the patient. What is the pH? And that's usually what I do, my friend. I get a quick iStat in the OR, where basically I get the coagulation profile and I get the pH and hematocrit and everything. If everything looks like it's normal, even though it was a battle in that abdomen, I close the abdomen. And I do my definite bowel repair and everything. If pH is normal, if everything else is normal. But again, this data needs to be, we need to put it out there again and see what are the true indications. Because like you know very well, there's a lot of people that are doing a lot of damage control that is not warranted.
You mean base deficit versus pH?
Base deficit, correct.
Okay.
And hopefully we'll be discussing more and more at the Pan American in Peru.
Everybody is invited to the Pan American Congress. Is going to be in Lima, and it's the best food in the world and everything else.
Yeah, Dr. Aurelio Rodriguez is going to welcome everybody over there, right, Dr. Rodriguez?
Exactly.
He's gonna be with his guitar waiting for us.
Yeah.
All right. Thank you so much.
Dr. Duchesne, thank you very much for presenting today. It's always an honor to have you with us. You really stimulated to be together with us as often as you can. Please help us with your knowledge and share your knowledge, your experience. And again, it was an amazing talk. And we definitely need to have some more pre-hospital case presented here. So, and bring all the professionals to discuss the kind of management as well. Thank you for bringing this up.
All right. Thank you, everybody. You guys have a very good day. Safe. Bye-bye.
Thank you all. Take care. Bye-bye.
Thank you.